report, Dr. Ringwald and Nevins. Very interesting sort of cutting-edge studies. Doug Zatzek from Harborview in Seattle. So I'm interested, A, in the coordination between your two trials, and if you could spend a little bit more time talking about your approach to the cost analyses, because I think from a policy perspective, that's going to be key. From the design of the study and all the upfront chart review or community organization, how are you costing that out? Looking at the intensity of the intervention, are you tracking costs on that end? And then also at the bottom, sort of, whether or not you do the sort of typical adjustments for kind of left-skewed data in the cost analysis, and whether or not you're tracking the potential leak into specialty settings and services.
Well, first on the coordination part, he's in North Carolina and I'm in Washington, and we talk on the phone. His is kind of, I like to call like the light approach, kind of the mass mailing approach. It's a little more one size fits all, and my approach is more intensive, personalized, and covers all the ERs. Is that fair enough?
Yeah, in our defense, we thought that the most realistic approach that we could afford, but also any other EDs that might care to adopt a program like ours, was basically say, here's a list of resources, good luck. We did not attempt to see where the patients went after they left the ED or not getting what they wanted, whether they were getting appropriate care in the community. That was simply beyond our resources, but we suspect that it's beyond everyone else's too.
So no verbal follow-up. I mean, basically, the data for your cost analysis are all ED-based utilization data, no verbal follow-up in your samples.
It's all hospital data, and I'm going to have my health economist stand up because I want you to talk to him, Sean Murphy. We have a dedicated health economist who's doing a significant portion of the financial analysis. So he's going to look at all the reimbursements that the hospitals got, what their reported costs were, and what the charges were, and we're exploring talking about some societal costs too. Are we not?
Hopefully. I mean, that's always kind of the holy grail. That's obviously very tough. So with most cost analyses, you obviously start with kind of a direct cost approach because that allows for comparison across multiple studies, because as you start getting into those societal costs, it's very subjective. In terms of what we did to analyze the data, as Dr. Nevin said, it's hospital cost level data, and this specifically was patients who were both admitted to and discharged from the ED. So we are going to do some broader analyses where we look at all resources used by these patients at the hospital. Unfortunately, we don't have the cost information for anything used outside of that. But regardless of whether they were admitted to or discharged from the ED. In terms of adjusting for the skewness that typically goes with cost data, as you said, I did use a generalized linear model with a Parks test for anyone who's interested in that. I can talk about more later. But and then I also did, as a robustness check, used generalized estimating equations to test it longitudinally, and the effect is still there. So it's a very solid.
That's great. No, I don't mean to take up the whole thing. You know, one thing you could look at is, so you have if you have Washington State CHARS data on these people, I don't know if they consented to that, but you wouldn't need, I mean, the big question is, you're doing a lot of work with your communities and your EDs, and, you know, everybody's going to, and then you have a case manager that you're paying for in the ED. Like, those things all cost money, and does this save, you know, on the utilization and societal end? One thing you do in Washington State is look at the CHARS data, and all you need is the hospital readmission data, because one hospital readmission counts for just tons of sort of, you know, ED visits and outpatient visits.
So we have looked at the cost of the program, and we intend to cost what this study would cost to do. The only thing I can say is kind of a real-world extrapolation is we have continued this study as a community nonprofit because we had such a good community collaborative, we didn't want to let it go. So we're sustaining all this work on an ongoing basis in the Tri-Cities with funding from payers right now. But we hope to factor those costs in with everything else in our analysis.
Yeah, and as an aside, we did do, before we did this randomized trial on Dr. Nevin's program in Spokane, I did an analysis, and it was more of a convenient sample and a pre-post analysis, but we did find it to be cost-saving, and you know, going forward, I do plan on doing some more analyses. We're hoping to get reimbursement information on everything, and you know, so we can look at the hospital's net income and and like he said, also get a more accurate picture of what the program's actually costing. But so far everything has been very good along those lines.
Hi, I'm Jen Hannum from Winston-Salem, North Carolina. My question focuses around the posting of posters in the ED waiting room. You know, I've thought about this a lot. It seems like, I mean, patient expectation is a very important part of this. And, you know, you have the Carolinas health system and the Spokane model where it seems like individual patients were looked at and sent information, so they had expectation if they got the letters in terms of what to expect in the emergency department. Where I work, we do something similar where we review cases, and our medical director will send out a letter, describing expectation if they were to come into the emergency department. It's great for those individual patients that we can look at, but you miss, a significant number of patients that come in. So then you can do the general guidelines. But the question is, how do you disseminate that to the public? And I've thought about the posters in the waiting room, but I worry about the patient perception. And I wonder if you're collecting any data or have any data about patient perception of, those being in the waiting room, and if that's any deterrent or if that's viewed as, because you kind of talked about how the public perception was, but that was with the rollout and the delivery. And if the delivery of the posters is different in that, folks aren't kind of turned off by that or don't, have a negative perception from that.
Oh,
Right.
go ahead.
We have not had a big backlash from patients on the poster. I was involved in making the poster for Washington State and the revised poster, and I've learned that there's going to be a national poster that possibly was ratified by ACEP on Friday. I don't know if anyone else knows anything more about that. But I have not had a lot of blowback from patients and or ERs where people are stomping out when they see that. I'm in favor of the posters in the waiting room, but I'm a bigger fan of the posters in the patient treatment room, because then when I have that discussion and it starts getting personal, I can just point to this poster right here, and they can know that I'm not the bad guy. There's a bigger effort behind what I'm saying. So I think there's an EMTALA compliant poster out there now. We think we have one in Washington. And did you have posters in North Carolina?
We didn't have posters, no, but we did send that letter out, which I referred to the patients enrolled in the intervention group. And one of the things that I anticipated finding, which we did not find, was that patients in the intervention group who get the letter would be less likely to return at all than those in the control group, which was business as usual. In fact, we didn't find that. Patients in each group were equally likely to return at least once. So either they didn't get our letter, or maybe they didn't read it, or they didn't believe it, but they kept on coming back. So that may shed some light on the issue of posters.
It's interesting that, it's interesting that you say that they still come back, because my medical director's experience is when he writes these letters and sends them out, he says that expect them to come in shortly afterwards to, to kind of see how that works out. So
That's our experience.
Oh,
Yeah.
well, that could well be. Do you really mean this?
We find when we put someone on a guideline, they don't really probably understand it, but then after they come in a couple times, anecdotally, we think they figure out that they're not going to get what they want. They're going to get what they need.
If I could just answer, so we don't actually put the posters in the waiting room anymore. We actually put them post-triage, because there was some concerns whether, remember, the only way you find out if you have an EMTALA violation is when you get investigated and tell you have an EMTALA violation, in which case you're already behind the 8 ball. So we took the position that we'll let people come in and get triaged, and then they'll see the poster, and then they'll decide what they want to do. And they'll learn over time, since, as we've already heard, many of these people are repetitive visitors. We have not gotten any blowback either, although I will say, as I've said earlier, it's very hard to study this. I mean, first of all, there's a million pieces of machinery going on at the same time here. We also have a situation where, as many of you probably face, many people already were compliant with these types of guidelines to begin with. So to see if the posters actually make a reduction in prescribed opioid is going to be very difficult without having prescriber-level data, which is something we're not going to really be able to get very easily. So we want to know if the people that were high prescribers are now low prescribers, because the people that are low prescribers presumably haven't gone up in their prescribing and probably couldn't have gone down very much to begin with. So it is a fairly hard thing to assess. So we come back again to the types of qualitative research that we do maybe with patient surveys of satisfaction, things like that. We have not had anything that would suggest that there's a problem with it. No complaints and no changes in any other way.
What state are you from?
North Carolina.
Okay.
Could I make one comment, I think, that follows up on that? And some of you may remember, maybe 5, 6 years ago, we saw some poster efforts or letter efforts, particularly from the Southwest United States, that used information about giving us a false ID, false Social Security number, and the implication that underlied some of that was, I'm not sure I want undocumented patients in my emergency department. And I don't know if any of you saw those. They sort of filtered around maybe about 5 or 6 years ago, and were a bit scary. And I think one of the positive things that the poster letter effort could do is both help emergency departments think about what they can do, but also perhaps give some guidelines about things that we should not be doing. And I think that would be a service in the way of standardizing what we put in those letters and what we should not put in those letters. And I don't know if you remember that trend, but it was a bit scary, and it was tied up with a number of political trends in the United States that I think we want to stay away from. Just a comment.
Thank you for your work on ED care coordination. I think it's really promising. I'm sort of curious, what has your discussions been around specifically sharing of personal health information and HIPAA compliance?
That's the number one question. There's always, one of the first 3 questions is about HIPAA. And we really think it's simple, and we've addressed it this way for the 7 years I've been doing this. It's treatment-related information, and it's going provider to provider. We have this health information exchange, so to speak, now, and it only shares information if the one ER says they have that patient there. So that's kind of our carte blanche, and we feel like as long as it's being used for treatment, we're not mining this, we're not sending it to police. It just falls under HIPAA for treatment.
Marcia, do you want to add to that?
Yeah. Okay. Does that answer your question? Mostly with sharing the guidelines. I mean, how do you share guidelines between hospitals? Yeah, it's very uncultural in a lot of areas to share across corporate boundaries like that, but it's been reviewed by HIPAA lawyers in Washington, and we haven't had any challenges at all, knock on wood. And so we feel it's very treatment related.
I also wanted to thank you for doing such great work with prescribing guidelines and care coordination. One question that I have, I think as emergency physicians, we focus on our prescribing and the patients that are becoming addicted to pain pills. In my own community, I'm from Ohio, from Cuyahoga County, and what we have seen as sort of an unintended consequence of prescription pills becoming less available is we're starting to see that mortality from prescription pain pills is going down while heroin is on the rise. I'm wondering if you're seeing this in your community as well as you've become a little bit better at making these pills less available. And I'm kind of curious what other communities are doing to address that as well.
In a word, yes, but I'm going to cue Caleb because I think he's the national expert on this, and he has data behind it. Caleb, can you say something about this? So this is Caleb Banta-Green, and he's with the University of Washington, and I think he's the biggest expert in Washington about all the drug abuse trends. He's published on this exact thing, the spike in heroin now that we're ratcheting back prescription opioids.
So, and this came up earlier as well. Kavita mentioned it. Is this on? What's that? Just speak into it. So Washington State, as you saw with our agency medical director guidelines, Dr. Franklin L. and I back in 2008, those guidelines were promulgated. We started having laws. We really saw the bending in the curve for morphine, methadone, and oxycodone in 2008. And we saw deaths have been declining since then from pharmaceuticals among those under 40, not among those over 40. So and we're seeing a spike in heroin-related deaths among those under 40. So basic substitution effect it looks like. And basic point is that there are mitigating factors we can take, medication-assisted treatment, overdose education, distributing take-home naloxone. And so we're slowly working to try to do that. SAMSHA did put out, finally after 3 years, overdose prevention toolkit in August. If people aren't familiar with that, I encourage them to do that. It was initially targeted at opiate treatment providers. Now it's targeted all prescribers. You have a patient who's at risk for overdose, you should do overdose education, you should consider dispensing take-home naloxone. So we're definitely seeing the epi-trends behind that. We're getting a toolkit coming.
Right.
Finally, there's some federal guidance there. So what you're saying is correct, and there certainly are some things that we can be doing and providers can be doing.
And we just started a naloxone program in Cleveland as well. So.
If I can just comment too, I mean, this is one of those, it is clearly an unintended consequence, but I'm not exactly sure what we're supposed to do about it. So, if you make the argument that these folks who are no longer getting their prescription drugs are turning to heroin, we should therefore give them prescription drugs for them too. I know you're not saying that, but I'm not sure exactly, and your points are well taken. There are alternative ways to this. In New York City, it's interesting. Ironically, in some way, New York City's not really had the same prescription opioid problem that much of the country's had. And that really comes back to the fact that we have tons of heroin, and it's a good thing or bad thing, depends how you look at it. Yeah, and methadone is probably still about a third of our opioid deaths. We have about a heroin death a day in New York City. So we still have a tremendous problem with it. But, and in the demographic, I don't know how well you know New York City, but, each of the different boroughs has quite a different demographic. And our demographic of prescription opioid abuse is almost completely centered on Staten Island, which is a blue-collar population, which is exactly what it is in most of the country. The inner cities of New York still wind up having a lot of heroin use. And the real population center is in Staten Island. But even there, we've not really seen a big uptick in heroin use with the restriction of prescription drugs. But again, it comes down to that fact, getting people into treatment, getting them on buprenorphine, methadone, I'm not so sure, but these naloxone programs and other things may be the best solution, because I don't know that we could otherwise continue to prescribe because we're afraid they're going to switch to heroin. And I know you're not saying that, but I'm just making that as a statement, yeah.
See, people are saying that, though. There has been rumors because we really ratcheted down the supply of opioids in the ER in this metropolitan area. So there was just a few naysayers that were like, oh, you're pushing everybody into heroin. So we do hear that. No, and I know that's not what you're saying.
My argument, of course, is that the outcome that we care about is mortality. And if we don't see mortality go down because the guidelines are changing, then we need to put other strategies.
Yeah, the best strategy is prevention. And if I could just say that again, that was my original point.
Eventually, we're going to get a hold of Social Security data, if our government ever reopens, that will enable us to look at deaths attributable to any cause in our intervention versus our control group. These data are actually relatively easy to get if you can provide the Social Security Administration list of the Social Security numbers of your patient population. So we will be able to look at this indirectly that way. And we don't know what we're going to expect to find.
Chris, I was kind of surprised in your study you had a dropout rate of about 5% because patients came back with suicide on your flow chart.
Yeah.
That seemed pretty high, or they came back with a complaint of suicidal ideation, I guess. I can't remember exactly what the slide showed. But you had a large number of patients drop out, 10 out of 200, because they came in and they were suicidal. And I think that goes to some of your point. What kind of measures can we put around this for, an ED, for a community, or for however you want to look at it, specifically looking at some of the issues surrounding substance abuse? Because I think there's a dearth of measures out there right now that you can take to a community and say, you guys are not really doing a good job managing your substance abuse patients, your chronic opioid-dependent patients, your alcohol-dependent, whatever it is. And I just don't see anywhere out there saying, well, here's a really good measure for a 80,000 visit ED or a rural ED for the number of prescription opioids maybe you should be giving in that community or however. And I'm just wondering what your thoughts are on that topic.
Marcia.
Right. Well, I think you just highlighted one of the weaknesses we felt we had with our study. And we actually, in our initial proposal, wanted to do a follow-up on the patients. And as Chris said, did not get the resources to do that. I will also tell you that with regard to the patients that were pulled out because of suicidal either attempt, which was rare, but it was mostly people, we'd see the documentation, the patient is talking about hurting themselves or whatever. If there was a whiff of that, we pulled them out. So we had a very, very, very low threshold to pull these patients out. But having said that, and we did give, you know, as comprehensive a list as we could come up with for the different communities where the emergency departments were. Nevertheless, we had no way of knowing whether or not folks were able to get any sort of help in terms of getting into a care provider, getting their chronic pain taken care of, getting their addiction taken care of. And that, it's a problem, but it was beyond this study to look at that.
Because nationally, there's going to be metrics, there's going to be measures that we're going to do it, and we have metadata now. We have so much data, you know, very little information, lots of data. But getting to the point of where you could turn around to an emergency department and say, hey, you guys may be prescribing too many narcotics, or, hey, there was a lot of deaths related to heroin in your community, and, you know, 20% of these patients came to your ED within a week, and what did you do to try to prevent that? Did you do a SBIRT? Did you do any kind of program to help that, whether it's heroin or alcohol, things like that? So I'm just wondering if the panel can address if there's any national or anybody looking at this at a more global.
We do have a state initiative. As part of these 7 best practices, the state now reports to every ER on an individual provider level how many pills they are giving on average to patient review and coordination program patients. So the 7 best practices focused on these lock-in patients, which are, they're frequent users of medicine in general, and Medicaid can lock them in to only see one doctor. And they wanted to focus on those patients. So they send us a report on everyone in the ER and how many pills they're giving to those patients in general. And I think that's just the tip of the iceberg, that we're going to get reporting on an individual level of what our average pills are. And we're shooting for, nobody should, I personally am shooting for, you shouldn't be on average prescribing more than 20 pills. If you're getting around 22 or 23, in my personal opinion, you may be kind of a higher prescriber. That's pills per prescription.
So Carrie Broderick from Denver. So I guess, you know, when I'm looking at the title of what this conference is about, addressing patients with substance use disorders, I hear a lot about cutting off the flow and not really about addressing the substance use disorder. And I do believe that this is a problem that has to come from both ends. It has to stop the flow, which we have been guilty of, all of us, you know, for various reasons. But we also have to take care of the patients who have developed the problem. And I am concerned with what Dr. Kapp said. I mean, there's good literature, I think, D'Onofrio, maybe she'll speak later, about the patients who are addicted, how quickly they'll turn to heroin, and getting off heroin is a lot more problematic. I haven't heard a lot about what people are saying, what they're doing when they identify the problem, getting people linked with care. I haven't heard that. And of course, this conference is maybe biased because it's looking a lot at NIDA and about, you know, stopping opioids. But stopping the problem, people who have developed an addiction, right, they still have the problem even after you're cut off.
I love that comment, because a home run for us is when we can get somebody into treatment. And I think we need to recalibrate ERs to have that, just like they can refer someone to a cardiologist, but they don't. It's really a culture problem in emergency medicine that we don't know how to talk to patients about addiction, the general ER doctor, not the people in this room, and we don't even know how to get the ball rolling. And I've been doing this for a few years, and I still struggle to get people into treatment. The red tape is incredible. If you're not on Medicaid, you have to be on this other program, and then it's really hard. And I think you're right. The next level is we need to protocolize how we're going to get people into treatment, not just hand them a list of numbers to call. I mean, that needs to be, we need to have like a code addiction we've talked about, instead, like we have the code stroke now in the ER and the code MI. That we really need to address that big time. You're right.
Well, you know, I think the afternoon is going to have a little bit more about that, honestly. But one of our 9 bullet points, the last one actually does address, on my New York City guidelines, does address that issue. And, you know, it's just a recommendation to screen and to refer and to do that. I mean, obviously that wasn't the intent necessarily of the guidelines per se, but that's one of the things we do clearly recognize as an issue.
I have one comment. You know, we're talking about how we can treat their addictions. We can't do anything unless they want to treat their addictions. And so to take that on is really a losing proposition. I mean, it isn't, it's maybe our responsibility to make it available, but it's their responsibility to choose to change their addiction.
That's true, but the thing we don't want to do is enable them. And if we're really enabling them, we need to really be honest with that. And the other thing is, you know, it's always viewed that we're being mean and this is punitive. I really feel like we're just doing no harm. We're just at first doing no harm, and we're not enabling them. And quite honestly, they need to go farther down. Some of these folks, they need to go farther down towards rock bottom, and we suspend a lot of people from rock bottom. And I don't think that's good for addiction.
No,
but
I
I know what
agree
you're
with you.
saying, though. You can't push that rock uphill.
You can't, and the other thing is if they turn to heroin because I won't give them opiates, that's not my fault. That's not my responsibility. That's their choice. I mean, I have two sons. I'm telling you this as a mom and an ER doctor. I have one son who chose to become clean and one son who hasn't. It's not the fault of anybody but that person.
Yeah. And go ahead.
You know, I was going to support you, and you know, this is a big problem, and you know, even the motivated ones that do go through any sort of program, the recidivism rate's incredibly high. This is a very, very difficult thing. All addictions are, you know, whether it's alcohol or tobacco, you could pick your favorite addiction. It could be a non-drug related addiction. I mean, all of these things are very difficult to treat. Prevention is critically important, no question. But also remember that I don't know the percentage, but not everybody that comes in looking for prescription painkillers is addicted. And there is that subpopulation we brought up before, too, of people who are seeking pill. I think you brought this up. Because there is value. I mean, you're pretty cheap by you. By me, it's about $1 a milligram. And so, you know, you can get a fair amount of money from a reasonable prescription. You can break a couple of $100 pretty easily. So what percentage it is that are in one group versus the other is a little bit unclear. You know, and there's obviously a lot of mix between the two different groups. So clearly, we have a role in identifying and offering treatment, but we can only take a horse to water, right? We can't make them drink, and that's exactly what we have to provide for them.
I'm just going to say that we are going to discuss that in depth in the afternoon about how to get people to take those horses to water. Again, can't make them drink, but the whole afternoon is going to be about screening and brief interventions and how we kind of get people into addiction therapy when they need it.
Thanks.
So.
Thanks.
Yeah.
Okay.
I've been a practicing ER doc for about 30 years, and I recently decided to join a practice that treats addicted patients. And one of the things that I've run into is there are way more patients seeking treatment for addiction than there are doctors who are authorized to prescribe Suboxone or any other treatment program. And for different reasons, some people that come into the practice have been in one modality of treatment that they don't find satisfactory. They want another. In the 3 months that I've been practicing, it took me 3.5 weeks to get the 30 patients that I'm allowed to have for the first year. And some of them are coming from over 100 miles away. What is being done to address that problem from the other side? How are we going to get people who want and need treatment to a physician who will treat them? And what is, you know, what can we do to remove the stigma from people who treat addictions? Because there's some of that still out there as well.
Yeah, I bet Megan's going to tell us that that's the afternoon's discussion.
We definitely need more Suboxone and methadone providers. I mean, our methadone program's completely full. Is it hard to get methadone in New York City?
It's hard. I bet you can get it, but you know, we've been trying to push people towards Suboxone therapy. Honestly, buprenorphine's just it's a much more palatable therapy overall. You know, so that's where we're going. We have big clinics available for those.
I wish Nora Volkov was here from NIDA because she could advance the argument about the brain disease of addiction of these drugs and how they affect the brain and change the brain over time. She'll advance the argument of being a chronic disease similar to diabetes, hypertension, and congestive heart failure that needs to be treated in that way. But we have a system right now that gives some voice to parity, but it doesn't treat the patients and give them the same access through insurance to the same treatment. And I think that's part of the issues that we need to address. I don't think it changes the paradigm here that you have to deal with this problem that we've created in some ways. You know, pop a pill for every ill if we have the money, honey, you know.
You know, if I can comment, I mean, one of the differences that we see with this problem, honestly, is that there's two sides that are diametrically opposed to this problem, right? Unlike every other medical problem, nobody's out there saying we need more cancer, we need more diabetes, right? But there are plenty of people out there saying we undertreat pain, we have to give more pain medicines, and then the other side saying you're giving too much pain medication, the world's addicted to your drugs. So we're constantly in this tug of war between these two sides, and we fall pretty squarely in the middle with very little that we can do to prevent it other than the things we've been talking about here. So while I agree that this is a chronic disease, it's something that's so much more complicated than every other chronic disease we routinely deal with.
I would like to speak to my personal frustration. I've been in public health now for 25 years. I've recently made a transition into studying issues related to controlled substances, and there's no right or wrong answer. Is there too much? Is there too little? Who knows? What is your objective? Well, we don't have any. The objective, I guess, is we get the right drugs to the right people. What are the right drugs? What are the right people? We don't know. What is it that I'm trying to prevent? Anyway.
So I think we're actually over time, but the discussion's been vigorous, so people preferred that to getting through quickly.